Welcome to SurgiColl, the podcast. SurgiColl, which is short for Surgical Collective, is the first open access journal focused on publishing the latest evidence-based literature on the surgical specialties. The journal publishes quarterly and includes peer-reviewed original research, systematic reviews, current concept reviews, case reports, and surgical techniques. Today, I'm looking forward to our discussion on the recently published article in SurgiColl titled Skeletal Metastases of the Pelvis and Lower Extremity, a review for the Non-Oncologic Orthopaedic Surgeon. In addition to this article, we will also do a bit of a deeper dive on just metastatic disease in general. So for this episode, I'm excited to be joined by an old friend and colleague, Dr. Christina Gutowski. Dr. Gutowski is an attending orthopedic oncologist and orthopedic faculty member at the Cooper University Hospital in Camden, New Jersey. Dr. Gutowski is a graduate of our Thomas Jefferson Orthopaedic Surgery residency program and also is a graduate of an Orthopaedic Oncology fellowship at the renowned Memorial Sloan Kettering Cancer Center in New York City. So Nina, thank you for joining me.
It's a pleasure to be with you. Thanks for inviting me.
Of course, it'll be a fantastic conversation. So let's talk a little bit about a couple basic things so people get to know you a little bit. So what drew you to your specialty of orthopedic oncology after you completed your orthopedic residency?
So I'm asked this question all the time, and I laugh because I found it hard to answer this question without kind of inadvertently like bashing the other subspecialties, or at least sounding like you're comparing yours to the rest. So I'll try to avoid sounding like that when I answer this. But I chose orthopedic oncology kind of for three reasons that I've crystallized only like with time as I've kind of reflected back on that whole decision-making process. The first is the variety that the subspecialty offers. What I do is so broad, and I would argue it's by far the broadest of any of the subspecialties in terms of who I take care of. You know, I take care of everyone from children to octogenarians. What I take care of: bone work, soft tissue work, benign tumors, malignant tumors. What I do in the operating room: sometimes I'm taking things out, sometimes I'm replacing huge areas of bone, sometimes I'm fixing huge areas of bone. So the implants I use are extremely varied, and I loved that variety because I hate being bored. Then number two is kind of along those lines. I think orthopedic oncology is extremely like intellectually rich in the sense that you have to think so much. In some specialties, the diagnosis like isn't really in question. For example, like I could show you an X-ray of an arthritic hip, or I could show you an X-ray of an ankle fracture. And we can all agree immediately that like what's going on there. We can debate how to treat it for sure, but the diagnosis isn't really in question. As compared to in tumor, like sometimes 80% of your work is just establishing the diagnosis by piecing together all of the data. And then you have to kind of debate and think through your treatment options. So you end up doing just a ton of thinking and multidisciplinary collaboration to try to establish a diagnosis, which I thought was really fun. It's almost like a logic puzzle or something like that. And thirdly, like just in general, like it's an extremely challenging specialty, emotionally, personally, technically, mentally, and challenge energizes me. It always has. And I wanted to find something that I was going to do with my life that would kind of ring true to that.
That's a great answer. And I would actually throw in a couple things, working with orthopedic oncologists for a long time, obviously, as you know. I also think that I throw in there that it's never, like you said, it's never the same thing for certain. And it requires a lot of, I would say it requires a lot of creativity. There's a lot of creativity because a lot of surgical specialties, including ortho and others, it's kind of, there's a certain algorithms, you follow different algorithms for different things. And they're relatively straightforward. And there's always these few outlying things that are always interesting cases, if you will, or unusual. But I think in orthopedic oncology, almost all the cases have some level of creativity because no one cancer case is never the same as another cancer case. and the amount of bone involvement, soft tissue involvement, the patient dynamics, all are very, very specific, and you have to customize. The second thing I throw in there is one thing that I find unique to orthopedic oncology is the multidisciplinary approach. Most surgeons are in their box doing their things and really don't need to interact a whole lot outside of that specialty. Maybe a few consultants here and there, but pretty much are kind of self-sufficient. But oncologists, or orthopedic oncologists, by definition, have to be working these multidisciplinary teams with regular medical oncologists and other diagnosticians and other radiation oncologists and medical oncologists and radiologists and what have you, and other specialties. So I think it definitely takes a lot of teamwork to manage patients too. So I would throw those two things in there too. I don't know if they make your list at all, but I would throw them in there too.
Yeah, no, those are two of like the greatest advantages of the specialty that I really love as well.
Yeah, for sure. Well, then, so you're practicing at Cooper. You're an academic surgeon there, part of a residency program there. What inspired? And you wrote up. You submitted this paper that was an important paper published in SurgiColl. So, what inspired you to do clinical research in general?
So that's a great question. There is so much to study in orthopedic oncology. I think it comes from the fact that we do so many things. We don't do everything really well. There's such an opportunity to get better. And our numbers are really small compared to some of the orthopedic, the other, orthopedic literature, and then some of the other oncology literature. A sarcoma is 100 times more rare than some carcinomas. So there's still so much work to be done, and clinical research is really how we drive the field forward. And I don't think that we would be able to make the treatment recommendations and optimize, our treatments to the point that we could today if we weren't standing on the shoulders of the people who did clinical research over the last 100 years in orthopedic oncology. And, I think it's important to kind of continue to pay it forward and study what we do to ultimately drive the entire field forward.
I throw in there to build on what you said and why you do research is I think orthopedic oncology, like I said, is a small community. You're dealing with really low volume in terms of primary cancers involving bone. And I know we're going to talk more about metastatic disease today, but when you talk about primary bone cancers, your sarcomas, they're so uncommon. Obviously, you know that much better than I and most, that you have to look at it scientifically. Every case is potentially a learning case. You have to compile these patient experiences. Then there's all these cancer treatments that are being, offered oftentimes in clinical trials, oftentimes in these very controlled settings. So I find most orthopedic oncologists, first of all, A, you find yourself in academic centers, and B, the nature of your work kind of almost requires you to kind of be involved academically. But despite that, I applaud you for the work, because it's important to advance work, especially when you're seeing things that are not as frequent. So you have to, draw as much information from it as you can to improve care beyond that point, right? So I can definitely appreciate that. All right, one last fun question, and then we'll get it going. I always ask this one question. So before we get into your paper, what would you say is your most favorite or most hated medical TV show or movie, and why?
Favorite has got to be Grey's Anatomy, and I'm sure plenty of people have answered that question with that answer, but I was in college at the absolute peak time of that show, and it just brings back so many awesome memories of watching it with my friends. And at the time, half of us were pre-med, one of us ended up going to medical school, but we were all just so enthralled with the drama. And at the time, we thought that that's what being a surgical resident was going to be like. It was so ridiculous and so glamorized. They chose not to show the mundane 90% of a surgical resident's day, but it was a great time in my life, and it brings back a lot of memories. Least favorite, I am going to have to say that weird show, Dr. Pimple Popper, because pretty much on a daily basis, someone will say, oh, like, so you take out tumors like that woman on that show. And I just like I don't even know where to begin with that comparison. And I learned like
That's
many
so
years ago not
funny.
to take it personally. But yeah,
So wait, so I got to ask you that. So wait, patients are equating um,
sarcoma resection.
sarcoma surgery and bone cancer surgery as taking out. I've never watched the show, like taking out.
So
What are they
honestly,
taking out?
I
Like
haven't.
lipomas and stuff, and different
Yeah.
sebaceous. Like, what are they
Yeah.
taking out?
Yeah. So I think I've never really watched the show, but I do think that the main character excises some subcutaneous lipomas and kind of removes them in her office or whatever. And when I describe how I take out either, benign or malignant tumors, about working around the edges and lifting them out, that just like triggers that memory for them. And yeah, they compare me to her all
Wow.
the time. So I don't even know what the character's training is or anything, but
I think you have to at least watch an episode or two of that show just to get some frame of reference. So that's funny. But just going by the other show, Grey's Anatomy is funny because I think it's still on TV, by the way. So that's a bonkers show. That show started when I was a fellow, actually. So it's been around for almost 20 years, which is crazy. And my equivalent show to that when I was in college, ER had come out and people were absolutely enamored by that show. That was like must-see TV. Like we would watch that show. This is before internet and cell phones and all that stuff. Like that was a show we all sat down and watched. So
Yep. No, it's the exact same analogy. And it was must-see TV. Like people would get together in groups and watch.
yeah. Indeed. All right. Well, listen, Nina, let's get into your article and let's focus on that a little bit. So in the article, you do a great job reviewing the nuances of metastatic disease, emphasizing the importance of tissue diagnosis, lesion characteristics, patient dynamics to guide treatment. And so oftentimes the skeletal metastasis is a surprise to both the patient and the treating teams. What happens to us daily at the hospital and rounds, we'll see, in conference, we'll see a pathologic fracture. So let's start with, what do you think are some of the common mistakes that should be avoided by surgeons who are treating these without access to an orthopedic oncologist? They can't just text you and say, hey, what do you think about this? So I'm sure that, and as you know, and I'll just add to it a little bit, is that tumor surgery is something that makes a lot of people nervous on the surgical side because they don't want to ever mistake a metastasis for a primary, even though the ratio is like probably 20-1. It's almost always metastatic. So what are some of the mistakes you would guide and tell people to avoid?
Yeah, so there's so many things, so many ways I could answer this question. That's why an orthopedic oncology rotation for multiple months is really valuable in an orthopedic residency, because there are just so many things to learn. And it's not just like memorizing facts, it's just like establishing an approach to a metastatic disease patient. You really have to approach them differently than you would someone with a simple diagnosis. But if I had to answer, if I had to give you like a couple answers, I would say, first of all, philosophically, I think of metastatic carcinoma like a chronic disease. Okay, so like diabetes, hypertension, multiple sclerosis, okay, even HIV, like at the present time, is a chronic disease. You can live for decades with those diseases if they are under control. I would argue that you could live with them for decades and die of something else. Now, metastatic carcinoma, chances are, will eventually kill a patient, but they can live for, I have many patients in my practice who have been living with metastatic disease for decades. And we're not always doing surgery at the end of the patient's life. And I think we have to stop thinking about it that way. They may live with that construct that you give them for 10 years or more. So you have to do a good job, and you really have to think about giving them a durable solution. It's almost easier when the patient isn't very high functioning, because people almost feel like, oh, they're never going to walk on this, or, oh, they are likely, not going to be alive too much longer. But the pressure is on because these patients are working. They are exercising, and they are going to live for a decade with what you give them. It has to feel good, and it has to work. And it has to be durable against future disease progression. So that would be my first tip, is like this is not an easy thing. It's really hard to give someone with poor bone quality and a progressive disease a construct that's going to work long term. It takes some thought and it takes some technical skill. Secondly, you hit on it already, and I'm going to take the opportunity to say it again. You cannot assume that when someone has a history of carcinoma thought to be cured, that their first skeletal lesion is that thing, because they can certainly have a second primary. It can either be a bone sarcoma that started in that bone, or it could just be a second metastatic primary, either from a different organ. It can be multiple myeloma, which is a diffuse skeletal disease. And it's really important to biopsy that lesion before you really start thinking about treatment, because treatment strategies can vary considerably depending on what those cells are. So making that assumption can get you into trouble. And like you said, you'll probably get away with it many times, but that one time you get caught making that assumption will haunt you and is really, really bad for the patient. So you just have to get in the habit of understanding what you're treating before you treat it.
Can we stop for a second and go a little bit deeper on the diagnostic part for metastatic bone disease before we get into maybe some talk of skeletal stabilization strategies? So biopsy, I think, is central to this. You can't assume. So they have a known lung CA. You can be pretty confident if you see metastatic bone that, particularly based on the pattern, whether it is or isn't. But that's probably an easier decision because you have a known primary, and then the Mets match up in terms of its characteristics. But oftentimes you just see a pathologic lesion, right? And you're not sure. So what are some of the basics? So let's say they're dealing with in your paper focus on the lower extremity. So let's say you come in with a pathologic fracture of the femur or an impending pathologic fracture of the femur, Morel scores that are above 7 or so, or 9 or so. Do you do a biopsy first and then do the stabilization? Do you do it all in one sitting? What do you advise surgeons?
That's a great question. The way to always avoid an issue would be to do a biopsy as a separate procedure. You can do it with a needle, or you can do it, with interventional radiology, or, some musculoskeletal radiologists will do needle biopsies with image guidance, depending on your institution. And they would do it a few days ahead of time. Usually you can get a pathologic result within about 3 days. And if it looks like cells that traveled to that bone from somewhere else, so it's technically a metastasis in the bone, it is safe to be inside that lesion. So you can drill into it and scrape it out. You can put an instrument, you can put an implant through it, such as a nail, but it's safe because the cells are already bloodborne. That's the only way they got there. So by getting inside the lesion and kind of spilling it, you're not doing any more damage than kind of what's already been done. If you do if you try to do the biopsy and the procedure all in one, which we do sometimes, that's what you need to do is a frozen section, which is where the patient stays asleep. The surgeon breaks scrub, takes the small biopsy specimen down to the lab, and in about 10-15 minutes, you've got those cells on a slide with an H&E stain. Frozen sections are about 80% accurate. So chances are, if you are confident with your pathologist that you understand what those cells are telling you, you can return to the OR, and if it's a metastatic lesion, you can proceed with your surgery. But it's not that uncommon that the frozen section is going to be a little bit confusing, or they're not going to be able to give you a definitive diagnosis. And there's a chance that those cells in that tumor started there. They look mesenchymal based. They look spindle. They don't look like they're carcinoma cells, which are epithelial. And it's possible that this is a primary bone tumor, possibly a primary malignant bone tumor. That type of thing you cannot be inside. You have to do a wide excision of it. And with a wide excision of a primary bone tumor, you can cure that patient, meaning every single last cell is out of the body. If you go intralesional on it, there goes that possibility. So I would caution people who are unfamiliar with their pathology department and they're a little unfamiliar with frozen section technique to rely on doing the biopsy and the treatment in one. Even though it adds to a couple extra hospital days, even though it can delay treatment a couple days, you'll always be safer if the pathologist has a few days with the cells to do a couple extra studies and give you a really good definitive diagnosis.
I think that's great. And I'll throw in a couple, community perspectives. So as you know, I'm an academic upper extremity surgeon, but I do a lot of ortho trauma surgery. A lot of those kind of complex trauma cases come to me. And I can think of at least a half a dozen metastatic lower extremity cases that I've had. And I've embraced that strategy at the hospital where I work at, where there's not a tumor service, where if it looks like a metastatic lower extremity fracture, not impending, but truly a fracture. If it's impending, then you can wait and do a biopsy through IR. I agree with that. But it's fractured, right? So I'll take the patient to the OR and get the specimen using biopsy principles, making sure I'm in a compartment, not spreading, etc. And here's the key. Before you go to the OR, you talk to path and say, I'm bringing a fresh frozen. They got to know you're coming. You can't tell them, you can't show up at 7 p.m. They're all gone. They left at 3:30 p.m. Right? So they got to know you're coming. It's got to be during working hours. They don't have the same schedule we have. And I think you, as a surgeon, you have to hand deliver it. So I literally would walk. So the resident stays in the case and waits. If we're rotting, I'll say you can put a guide wire in the top of the femur if it's involved and just wait there, but don't open. And then and we'll go upstairs and look at the path together. And I would say majority of the time they can tell what it is very quickly, whether it's epithelial or not. But I've had a case where they couldn't tell. And maybe it was just a bad specimen that I brought up to them. But we had to abort at that point and say, okay, that's it. And so we closed up shop and said, that's all we're going to do today. Until we got the definitive. So these are really infrequent problems for the non-orthopedic oncologist. And I think that having some simple strategies like that helps to keep you out of trouble in terms of how to approach this.
Two things that you said were really important. Number one, you take it to them, you explain what you're looking for. And specifically, what you can tell them is, I just need to know if it's sarcoma or anything else. You don't need to tell me what the diagnosis is. Just tell me which bucket it's in. Is this a primary bone tumor, a sarcoma that started in the bone, or is it anything else? Because as long as it's in the latter bucket, it's safe. It traveled there from somewhere else. You can't do worse for the patient by rotting it or doing whatever you want to do. So that's really important. The other thing is, just you can actually save some time by working as a team with your resident or whoever is in the operating room with you. And one person kind of goes, the other person can get as far as they can with the case simultaneously without instrumenting the lesion. And if you are unsure of what you're seeing on that frozen, you just call into the room and you say, stop.
Right.
And if you talk to the patient about that ahead of time, that there's a small chance that they will wake up with an incomplete operation because you're doing the safest thing for them, they get it.
Yeah.
They will not
be. I think that's really, really important. I think it's an important point to stress. So I'm happy we talked about that. Let's talk a little bit about skeletal stabilization when needed. And again, this is broad. It could be so many things. In your paper, you cover pelvic lesions and femoral and tibial lesions. So let's focus on whichever the ones you want to, but some kind of broad kind of teaching points when it comes to skeletal stabilization in metastatic disease and lower extremity.
So I think the most important broad concept to keep in mind is that this bone's never going to heal. So it's not like fixing a traumatic fracture. I remember we used to have, when I was in residency, we had a traumatologist who used to say for our really elderly patients, you cannot leave the operating room after having fixed a fracture in an elderly patient if your fixation is so tenuous that you're going to make them non-weight bearing. Because old people are like sharks, they got to move to live, and old people can't be non-weight bearing because they all have such balance issues. They can't hop. They can't put one foot down with their walker, but not put weight on it. They just physically can't do that. It's kind of analogous in tumor surgery, a little bit different. I would say you can't leave someone with a construct where you're saying, it'll be okay once the bone starts to heal. We just need to get this bone to heal, and then, they'll be able to weight bear. It'll be fine. Because you cannot rely on that. Pathologic bone is super unreliable, especially when you radiate it, especially when there are big bone defects from tumor that's blowing out of the canal and destroying the cortex. You have to give them a really durable construct. So have a low threshold to use cement to bridge defects. Have a low threshold to get into the tumor, scrape it out, decrease that burden of disease to prevent, a local progression at the site of the metastasis. And have a low threshold to consider excising that pathologic bone completely and replacing it with like an endoprosthetic. We have a pretty low threshold, as we mentioned in the manuscript, to aggressively treat proximal femur lesions, especially when there's just a huge tumor burden in the area. We resect the whole proximal femur and put in a PFR. The implants are good. Intercalary femoral implants for big destructive diaphyseal tumors. Those tumors hurt even when a nail is through them. They still hurt. Those patients still have micromotion. So really consider, is fixation but leaving that pathologic bone in there, is that the best option? Or should we really be, being a little more aggressive, especially, as I said earlier, in the setting of patients living longer with the great biologic treatment options that we have these days? So that would be a general principle, is don't rely or assume that bone is ever going to heal.
That's really, really good advice. And I don't think something that I often hear said, frankly, that it's not necessarily going to heal. It's almost, you assume that it's a fracture. Ultimately, once you stabilize it, it will heal. But I think that's a better mindset that it may not. And being aggressive with debridement of it, and being more stout with your fixation strategy, replacing when you can, PFR, DFR, etc. When those things are options available to you, using cement. Recognizing this may not heal, using 2 interlocks instead of 1 interlock, because one's higher likelihood that one of them is going to fail, so you need to have a backup interlock. Little things like that go a long way. And we actually had this discussion recently about when you use 2 interlocks, and I'm going to add this to my list of when I use 2 interlocks, because I will typically use 1 interlock because I'm lazy. And now when you use 2 interlocks in a pathologic fracture case, that's really good. No, that's a really good one. So thank you for that.
That's to be robust as possible.
Absolutely. So let's talk a little bit about post-op. This is an area that's always great to us as surgeons. So in many cases, post-op radiation is indicated to slow progression of the cancer. Any particular principles surgeons should know and or should they anticipate relative to the surgical fixation and or bone healing? So we talked a little bit about already that poor healing potential in general. Now you take radiation into the equation. I find surgeons are all over the map in terms of how they view radiation. Some are ambivalent, some are scared about radiation. They think the skin won't heal and nothing will heal. How do you think about radiation relative to skeletal fixation?
So we're talking about radiation for metastatic disease. So radiation for metastatic lesions is a lower dose than the radiation that patients get for, say, soft tissue sarcoma, where the standard of care is radiation plus surgery in either order. And depending if you do the radiation before or after soft tissue sarcoma resection, you kind of inherit different complications or kind of adverse side effects of the radiation. The dose that patients get to a metastatic bone lesion is about half of the dose of what a soft tissue sarcoma gets. So right off the bat, it's a little bit of a different thought process. Most patients will get post-operative radiation after you say nail a pathologic fracture or nail an impending fracture. Though the tips I have for surgeons is, number one, you should not start your post-op radiation until your wound heals. Mm-hmm. So, you got to close well. So on day 15, your sutures come out on day 14, and day 15, they're getting simulated for their radiation. Mm-hmm. You have to have a really good working relationship with that radiation oncologist where, you literally just text them from office hours and say, green light to start radiation. And the patient already has an appointment with them the following day. Mm-hmm. But you can counsel the patients that, there are some side effects to consider. Usually the dose is pretty well tolerated. However, they can have some woodiness or like some fibrosis of their soft tissues. So a good way I explain it to them is, your muscle and fat and skin normally is like spandex, like picture like spandex pants. After we radiate it, it turns into burlap. It just doesn't stretch. It doesn't really even bend that well. It feels kind of bulky and tough. Like a filet mignon versus an overcooked steak. So you have to be ready for that fibrotic change to the soft tissues. And certain patients will have different responses and different severity of that fibrotic change. I think my personal opinion, and I would love to study this, is it has something to do with the systemic treatment they're on. But that is not at all evidence-based. It's just my experience anecdotally. I've had really bad reactions to the exact same dose that other people don't react to at all. And it not only can complicate wound healing, but it can complicate the healing of the soft tissues beneath the skin. So I always use non-absorbable suture to close fascia in patients that I'm going to radiate after, because you, again, cannot rely on that fascia healing once you radiate it 2 weeks after. So I don't want to have sutures that absorb, because that fascial repair is so critical. So I use Ethibond or some sort of non-absorbable suture whenever I repair fascia.
Got it. Okay, that's really useful. Mm-hmm. I like the spandex versus burlap distinction. I've had those discussions, and I personally am not too familiar with what effect it has on the soft tissue broadly. I would imagine to some extent it's probably reversible once that tissue's had some time to remodel out post radiation, but maybe not. I don't know. But that's an interesting way to think about it. That's really helpful. Thank you. All right. So listen, last question, Nina, and we'll close out our discussion on metastatic disease management. And this is that concept or question of when to transfer, when to consult, one of the ubiquitous kind of issues around ortho-oncology patients. So obviously in the setting of primary bone cancers, those patients should out of the gate preemptively be transferred and managed by an orthopedic oncologist with their multidisciplinary team. I don't think there's any dispute there. But what about in the case of metastatic disease, which is much more common? And when do you think, and again, this is very broad, so just kind of some guiding principles. And obviously it comes down, again, person to person comfort level and resource at the facility. But when do you think a surgeon should actively seek orthopedic oncologist consultation or transfer to, right? Because a lot of times it's a transfer situation for metastatic disease.
Yeah. So one really exciting thing that we're doing in orthopedic oncology now, it's been kind of explored over maybe the last 5 to 10 years, is percutaneous screw fixation in the pelvis for really painful periarticular metastases. In the past, periarticular, kind of periacetabular mets have been challenging. We radiate as long as we can, but they become really painful and can limit a patient's ability to walk, in which case, oftentimes it buys them a huge periacetabular reconstruction with screws and cages or custom implants, and it is a huge whack. Oftentimes it can be the beginning of kind of like a downward spiral for them. So we've recently been learning how to put in anterior column screws, posterior column screws, and kind of an LC2 ilium screw from front to back. And patients who are literally wheelchair bound coming into the holding area will walk out of the PACU and go home the same day.
That's really surprising with those large cannulated 6.5, 7.3 type screws like we use for SI fixation and lateral compression pelvic injury.
Exactly right. Through incisions, that are less than a centimeter, stab incisions to get these percutaneous screws in. The symptom relief that patients experience from those screws is really profound. Just kind of creating that tripod again of those columns of bone that have been destroyed by the metastasis. If they just get some bony stability around their acetabulum, they can instantly walk. It can be pretty profound, especially if then you radiate after, and that some of that tumor bone turns into healthy bone again. Then those screws are there to almost act as rebar as that bone grows. So this is becoming more widespread, and orthopedic oncologists for the most part are really happy to do this. I love doing that surgery. And that would be something that I want all orthopedic surgeons to know when they see patients with ambulatory dysfunction in the hospital or in their office from periacetabular disease. Previously, they're sick patients, they wouldn't really be surgical candidates. Now pretty much everyone is a surgical candidate for a percutaneous.
Are you using navigation for that, or are you just using fluoro and just like SI screws?
Yeah.
Right. Okay.
Yeah. Sometimes in the back of the pelvis, we'll use at least an O-arm but not even, just if you get a good C-arm and good views, you can safely pass pretty much any of those screws.
Wow. Yeah. I mean, generally for periacetabular lesions, there's not a whole lot to do, right? If the acetabulum's compromised or subchondral, you can put in a cage, but that's a big whack. And I mean, I don't do those, but I don't ever got the impression that those patients do great. And so that's a nice something smaller that you can do that doesn't burn any bridges, not a big surgical insult, et cetera. So, wow, well, good.
Yeah, so that would be something that comes to mind as a specific opportunity for at least calling us and potentially thinking about transferring care, because we can really help these patients who previously may not have been a candidate for us helping them.
And similar to that question, just for our listeners, is future directions of research, either in the space that we discuss, lower extremities, skeletal metastases, or something in general that you want to share, where you think that where there's a lot, there's always opportunities to study things, but where you're really excited about.
Yeah. So like you said, there's so much. So back in 2008, there was a great paper that came out of Memorial Sloan Kettering looking at breast cancer patients with metastatic disease. And they surveyed these patients about all of the surgical procedures that they had, and they had everything. They had general surgical procedures, they had paracenteses, they had intracranial procedures. And they said, what specialty provided you with the most durable symptom control? Meaning you got the surgery and you never needed to worry about that symptom again. And the answer was orthopedics. And that was like such a battle cry, I think, to orthopedic oncologists, that what we do really does help these patients. So as, I would answer your question by saying as patient-reported outcomes measures really become online over the next several years, I'm really excited to be able to use PROs to better capture the impact that we're having on patients, what we're doing really well and what we're not doing so well. So we can really focus our research efforts on those things. And again, unless you capture the data, you're never going to really understand that. So patient-reported outcomes and functional outcome scores, I think, are going to be really valuable for orthopedic oncology research going forward.
That's really a great answer, because for someone who doesn't read a lot of orthopedic oncology literature and has a very kind of cursory understanding of the literature, my understanding from much of it is survival outcome data, right? So how different interventions affect survivorship, right? Survival rates, but not necessarily patient experience, patient outcomes, which is what we do in most other things.
Exactly. Quality of life is just as important.
Correct. So I think that's a really interesting to highlight, and maybe less morbid as well. right? To focus on that versus just simply survivorship. So, well, listen, Nina, thank you very much for the discussion and for your expertise, your teaching, all the work that you do. Really proud of what you're doing, and always enjoy reading your work and seeing what you're up to.
Thank you for having me. Like I said, it's a pleasure to be with you. I really appreciate the invitation.
Absolutely. So in closing, at SurgiColl, we believe that open access publishing is the future of scientific publishing. It keeps costs down. It allows the authors to maintain the ownership of their work. And most importantly, it facilitates expeditious dissemination of the author's research to anyone with internet access around the world with no requirements to purchase access or pay for a subscription. So with that, thank you for joining us. Till next time.